Okay, so again, my name is Leslie. I'm one of the marketing representatives here at Rothman Orthopedic Institute. I'd like to thank you for joining us tonight for our lecture on shoulder pain, when to see a doctor. We have one of our sports surgeons here with us today. This is Dr. Fotios Tjoumakaris. Most people just refer to him as Dr. TJ because, as you could tell when I said it, that name is a mouthful. Dr. TJ sees patients out of 3 of our New Jersey office locations. His 2 main locations are our Egg Harbor Township office and our Manahawkin office. And he does also spend some time in our Cape May Courthouse site. He does his surgeries out of Atlanta Care, both surgery centers locally to our Egg Harbor office and also Mainland Hospital. So without further ado, I will turn it over to Dr. TJ from here and allow him to share his screen so that everyone can view the presentation.
Okay, hopefully we can get this going.
There we go.
Can you see it?
Yeah.
Okay.
You're all set.
I can see, so. All right. So can everybody hear me okay? Is that it? Yes, Les? That's good?
Yes.
So I want to thank everybody for joining in tonight virtually. Obviously, different format. We're used to doing these in person where people can kind of raise their hand and ask questions, but hopefully we can get questions answered along the way. As mentioned, I'm a shoulder and sports medicine surgeon. My name is Fotios Tjoumakaris. Just a little bit about me. My dad emigrated from Greece back in the late 50s, early 60s. I was born here in the United States in Philadelphia and then emigrated to New Jersey and then went to medical school at Rutgers. I did my residency locally in Philadelphia at University of Pennsylvania and then did my fellowship at the University of Pittsburgh. And came back ultimately and practiced at Penn for a little while, and now I'm back at Rothman here as I got recruited to come back where I'm from. So I'm actually from South Jersey. I grew up in ever since 2nd grade in a town called Linwood, New Jersey, and have been here most of my life, and then went away for college, medical school, and for a little bit of practice, and now I'm back. So taking care of a lot of my family, my friends, people I grew up with, and I think it's one of the best things that I could have done. So like many of you, I'm from this area. So I wanted to, let me see if I can advance my slides here. These are some of my hobbies. On the left there, that's my wife and my 3 kids. I like to cycle. That's me cycling up in Italy a little bit. My dog, I'm a big dog person. I've got my dog there, Rigby. And one of the big highlights of my life was being able to go to the Super Bowl when the Philadelphia Eagles beat the Patriots with my dad, my brother, and my 2 boys who are there in that picture. They're a lot older now. And I have a lot more gray hair now, probably from that game, but just a great experience. So tonight we're going to talk about the shoulder, and really, why do I love the shoulder? I really love the shoulder because it's probably one of the most complex joints we have in the body. Your shoulder has the most range of motion of any joint in the body. Because of that, we put so much stress across our shoulder joints. We ask it to put our hand in space. So without a shoulder that can move, you really can't get your hand in space and do the things that you need to do in your life, whether it be work, whether it be play sports, or even do menial tasks that you take for granted, like brush your teeth, for females putting on a bra, for guys putting in their belt around their back. So just those little things that we do every day, the shoulder is intimately involved with doing it. And when you have a problem with your shoulder, what oftentimes you realize is how much of your life it really affects. There's not really anything that you do in life that if you don't intimately use your shoulder to do. And shoulder pain can be disruptive. It can be disruptive to the things that you do from a job perspective, from a recreational perspective, and even getting a good night's sleep. And I think that that's what drives patients oftentimes to see us, is that it's one of those 3 things is affected. And most commonly, we see sleep disturbance as a big part of a shoulder problem. So tonight, I just wanted to educate everybody a little bit about the shoulder. And I think that starts with a general appreciation of the anatomy of the shoulder region. From there, we'll use sort of like the things that we do as physicians to try to discern what's going on with patients in terms of getting an appropriate history, some exam maneuvers that we put patients through, what kind of imaging things that we'd use to make a diagnosis, and then what the treatment options are. So the shoulder is really made up of a couple of joints. When we think of the shoulder joint, really we think of the joint called the glenohumeral joint. The glenoid is the socket, the humerus is the ball, and the shoulder is a ball and socket joint. That's really the main joint I think that most of us think of. That's what provides rotation to the shoulder, what helps us lift our arm up overhead. But there's a couple of other joints involved in the shoulder, and we'll see patients with these problems as well. One of them is the scapulothoracic joint. That's where the shoulder blade meets the rib cage in the back. Your scapulothoracic joint helps you to lift your shoulder in a 2-to-1 ratio of the actual shoulder joint or glenohumeral joint itself. So if I can lift my shoulder from 0 degrees down here to 180 degrees overhead, 120 degrees of that is the shoulder joint itself, and 60 degrees is the scapulothoracic joint. So it works about half the time that the shoulder does, but provides a stable platform for the shoulder. The acromioclavicular joint is the joint above the shoulder. It's where your collarbone meets your scapular bone. And you may have heard people say they had a separated shoulder when they were young, maybe playing sports. And that's when that joint on top of your shoulder, and for short we call it the AC joint, separates or dislocates away from itself. And the final joint of the shoulder is the sternoclavicular joint. And again, that's where the collarbone meets the sternum or the breastplate. And that joint we oftentimes can see in patients in trauma. They might dislocate that joint. It can actually even compromise people's airways sometimes. But more often what we see is arthritis at that joint. For some reason, particularly in females over the ages of 55 or 60, that joint can sometimes become arthritic and painful. And we'll sometimes have to do things like cortisone injections, anti-inflammatories, or anti-inflammatory gels to help those symptoms. One thing I want to touch upon about the shoulder that's different from the hip. So on the left side of my screen is the shoulder joint, and on the right side you see the hip joint. Both of them are ball and socket joints, but what's unique about the shoulder is that it's not a constrained joint. The hip is relatively constrained by the socket, so it's very hard to dislocate your hip joint with range of motion. Whereas the shoulder joint, it's barely constrained by the socket. We have much more range of motion of our shoulder than we do our hip, and that's why you'll see young athletes or people who fall from a height could dislocate their shoulder, whereas you rarely see a dislocated hip, except in the context of somebody maybe who's had a hip replacement or in somebody who is in a trauma. So the most important part, I think, of the things that we treat in the shoulder, and clearly probably more the substance of this talk, and the most common thing that brings patients to our office, is problems of the soft tissues of the shoulder. Sure, you can break your shoulder, fall, and hurt, and have trauma, but more common what we see are these wear and tear problems in the shoulder, primarily involving the muscles of the shoulder. The main muscles are deep inside the shoulder, and we call those the rotator cuff muscles. Those are primarily 4 muscles that surround the ball and socket joint, and what they do is they help keep the ball of the shoulder centered in the socket, and they help you to lift your arm and rotate your arm. The 4 rotator cuff muscles, the one on the top is called the supraspinatus muscle. You can see that right here, going from the shoulder blade and attaching all the way out to the side of the bone over here. So the muscle attaches to the bone with a tendon, then you have the fleshy part of the muscle, and then again, when the rotator cuff muscle comes over the edge, it attaches to the bone itself over here. All 4 of those rotator cuff muscles essentially attach in a very close location to one another. So when you have a tear in one of them, it can progress to becoming a tear in another one. So the one on the top, as mentioned, is the supraspinatus muscle. This is looking at the shoulder from the back. This is the infraspinatus muscle, which is in the back of the shoulder here. And then below that is the teres minor muscle. That's one of the rotator cuff muscles in the back. The last rotator cuff muscle is not actually this muscle down here, but it's actually a muscle in the front called the subscapularis muscle. It sits deep to the pec muscle in the front of the chest and provides internal rotation. So all these muscles combine, the main effect is to keep the ball of the shoulder centered in the socket and keep it stable, but each of them uniquely has its own function. The subscapularis rotating the arm internally, the infraspinatus and teres minor rotating the arm externally, and the supraspinatus helping to abduct the arm at the side and helping to flex it forward. So when do patients really see me? Well, I would say the majority of patients I see probably have had pain more than 6 weeks. They may have had a trauma where they just acutely fell, can't lift their arm. Patients might have night pain, or they may have had pain over time that has come and gone. It's been recurring pains. So maybe it bothered them, last summer, then came back around Christmas time, and now it's coming back again. So you thought it might just go away, and then the pain seems to come back. So I think all 5 of those reasons are adequate reasons, I think, to seek treatment. Most kind of like small little things like tendonitis or inflammation, a lot of that might resolve in a week or 2, but when it lasts more than 6 weeks, I think it warrants an evaluation just to see what's going on, make sure there's nothing more significant that we would worry about. Obviously, if you fell, hit your arm, or can't lift your arm, or sustain a fall where you went to grab something and you felt your arm rip, so a rip or a pop or something more significant like that also might be an adequate reason to seek consultation and seek treatment. So the main things that we're going to ask patients when they come to our office, first and foremost, is where does your shoulder hurt? And problems in the shoulder typically, obviously, will refer pain around the shoulder. But believe it or not, the shoulder has a complex mapping of where people experience pain. You might have a problem at the shoulder joint itself, which is right here, but might feel the pain down your arm more, down by your deltoid muscle, or even down in your upper arm. Some patients might even say, yeah, my shoulder hurts, but I'll also get pain that radiates into my arm. And sometimes people even complain of hand pain or even occasional transient numbness where they might feel pins and needles. Now, if that pins and needles last longer, that might indicate an underlying nerve problem. So the location does help point us in the direction of the shoulder, but where you specifically hurt doesn't always mean that that's the structure that hurts, as the shoulder can map pain in various areas. The most common times we'll see patients with arthritis of the shoulder have pain more in the front. People with rotator cuff problems will often have pain down the side of the arm, what we commonly refer to as policeman's patch pain, where somebody might wear a badge on their arm. That might be where they experience a lot of the pain, particularly when they have a rotator cuff problem. Younger patients who might tear their labrum or have a problem inside the joint might actually feel more of a deep-seated pain or have just more pain with activity. So those are the things we really want to know. We want to know the severity. How bad is the pain on a scale of 1 to 10? More often, people will report that their pain's more than 5. Otherwise, they probably wouldn't seek treatment. So we want to know, how bad is the pain? Are there things that make it better? Do you take anti-inflammatory medications? Do you ice your shoulder? Do you put heat on your shoulder? So what really makes things better or worse for you? Because that might indicate to us the type of problem that you have. For instance, arthritis is oftentimes alleviated by heat, whereas an inflammatory problem like a tendonitis or a bursitis in the shoulder might be helped by ice, because ice is a very effective anti-inflammatory. For the younger patients, or even patients that are involved in athletic or recreational activities, we want to know what makes it worse. Does it hurt when you play golf, or does it hurt more after you play golf? Indicating maybe it's more of an acute problem or a tear of something, or is it more of a degenerative problem that will bring symptom onset later? Under what circumstances did the pain begin? Did you have an injury? Did it just come on rather insidiously, which means really no known mechanism by which it hurt? And was it a sudden onset, or did you gradually start to notice that your pain came on over time? Does the pain radiate? Does it only stay at the shoulder, or do you feel that pain that goes down your arm? Does it go into your upper neck or even behind your shoulder blades? And again, we want to know about injuries. Have you had any injuries in the past? Did you dislocate your shoulder when you played football as a kid? Did you play softball? Did you golf? Like, what sorts of things have you done over the years that may have also caused a confounding problem with the shoulder? And lastly, we always want to know about prior treatment. One of the things I'll ask patients is, have you had physical therapy? Have you had injections in the shoulder? And if you have had treatment, what's been the efficacy of that treatment? Has it worked, or has it not worked? And that's why you're seeking out consultation. So really now it comes, we get the history from patients. Now, what are we really going to do about it as physicians? Well, we're going to do an exam in the office, hopefully an exam that doesn't put you through too much discomfort. We might run some diagnostic tests such as x-rays, CT scans in some instances, or MRI, and then hopefully we come up with a good treatment plan. So we do things like x-rays in the office, right? So an x-ray is a good initial screen test. One thing we might look for is tumors. You know, we want to make sure that somebody who presents doesn't have some underlying bone tumor. Now that's extremely rare, but certainly can be the source of some shoulder pain. The image on the left is an x-ray of the shoulder. And again, you can see the ball here pretty well. You can see the bone of the arm here. Here's the socket. Off to the side, you'll see the chest with the ribs. And this is the clavicle curving up ahead and the shoulder blade going behind. So an x-ray gives a pretty detail of the bone anatomy. An MRI image, which is the image to the right, almost looks like the x-ray, right? So in this image, you can still see the ball here. You see the socket here. But now we get more detail with the soft tissue with an MRI. We can see within the marrow of the bone right here. And then we can also see the muscle itself traversing across the joint. And from the previous diagram, we know that this is the supraspinatus. And we know that this tendon right here should attach to the bone over here. And we see this little area of fuzzy haze where there's a tear in this rotator cuff, and the tear is retracted a little bit. In other words, this tendon should be attached to the bone here, and it's torn off, and the edge is over here. Because remember, the muscle doesn't know that it's torn. So when you go to use the arm, it continues to contract, and you pull the tendon further and further away from the bone. So the answer, you know, that's what we do. We do x-rays, we do physical exam maneuvers, and then we'll get diagnostic testing. We don't get MRIs in everybody, The things that point us to an MRI might be that you have weakness on your exam. Maybe you had a trauma, and maybe you have a lot of inability to do certain things in the office. One of the things that we first do is look at the shoulder, and we compare your one shoulder to the one that's not injured, and we see if there's atrophy. What atrophy is the muscle starts to shrink if it's not being used. Or if it's not being used, then the muscle will start to go away from the bone a little bit more, and you'll have more and more dysfunction. And as that happens and you use your arm less and less, you'll have less muscle bulk on one side relative to the other. And that indicates to us physicians that you might have more of a chronic problem. Then we assess your range of motion. How high can you lift your arm up to the front? How high can you lift it to the side? Can you go behind your back? Then we'll do things like strength testing, resist strength overhead like this, out to the side, and then also inward. And then we'll do little provocative tests, move the shoulder frontward or backward to see if that evokes certain pain or symptoms. And all of those tests really tell us why you have a certain problem, or if you have a certain problem. For instance, people with arthritis will have a restriction in their range of motion because arthritis causes bone spurs to develop, contractures of the joint, and they'll have less range of motion. People with rotator cuff tears might have less range of motion when they try to move their arm, but if I move your arm for you, I may be able to move it freely. So your active motion, which means you moving it, and your passive motion, which means me moving it, is symmetric. Whereas with arthritis, your passive motion, is not symmetric. Whereas with arthritis, your passive motion and your active motion are symmetric, but both decrease. The same goes for a condition like frozen shoulder. Frozen shoulder is where the ligaments of the shoulder start to scar in and restrict your motion. So you'll have less active motion, and not just less active motion, but when I try to move it, it will also be contracted. But we'll differentiate that from arthritis, and that frozen shoulder patients don't have any arthritis on their x-ray. So many times patients will ask me if they have a rotator cuff tear, if they have arthritis, like, why me? Why did this happen to me? Many of them may have not had trauma in their lives. They may never had a problem with their shoulder. Then all of a sudden they present one day at age 60 or 65 and have a lot of pain in their shoulder, or maybe inability to move their arm, or weakness. And the answer to that is pretty much like what you see on the right there, that tire. It's a wear and tear phenomenon. Some people have genetic predisposition to wearing out tendons and joints. And in addition to that, just the activities that you did through your lifetime may contribute. For instance, as a tire, you can have a tire to last 20 years if you only go 500, 600 miles a year. But if you're going to ride 40,000 miles a year in your car, you're going to need a new tire after that 1 year. So people who, for instance, have pitched baseballs their whole life will wear out the rotator cuff a lot quicker. People who sort of don't do a lot of overhead activities, a lot of strenuous work on their arms, may not have problems with their rotator cuff for a long time until they get older, where eventually that degenerative process catches up with us all. So I would say 90% of the problems that I see when people have shoulder problems is because of a wear and tear problem, an overuse problem, or things that have developed over time. And then 10% of people will present with more of an acute problem. Maybe they fell, tore the rotator cuff, broke their shoulder, or they all of a sudden had an injury that where they had arthritis before, they didn't notice it, but now they start to notice it. So arthritis can sometimes present in that way as well. I think the main thing, the thing that I really wanted to get to in this talk is to really kind of hone in a little bit on treatment. As far as treatment goes, there's not a one-size-fits-all approach. Patients come to us with different wishes, different wants, and different things that they do in their lives. Some people play golf 5 times a week. Some people want to just knit or sew. And some people really just want to get a comfortable night's sleep. And the treatment for those patients will be different. Some people want more aggressive treatment for the same tear than somebody else who's not as active. So we try to tailor our treatment approach, not just based on what the MRI or the exam shows, but really what fits the patient the best. So it really is patient specific. Obviously, age plays a big factor in that. If you're over the age of 80 and you have medical comorbidities, like maybe you have high blood pressure, diabetes, aortic stenosis, problems with your heart, maybe you have a problem that might be surgical, but that could put your life at risk to have surgery, and that's not a great option for you. So we may do things like cortisone injections, physical therapy, to try to manage your problem like we would high blood pressure. We don't cure it, but we manage it, try to control the symptoms so that you can lead a functional life. So patients that are younger, that have a long lifeline ahead of them of having a shoulder that they need to use, might warrant different treatment. For instance, if I have a patient with a full thickness tear of the rotator cuff that's rather small, in somebody who's 80 years old, they might do really well with a cortisone shot and physical therapy and really get a high functional level because they're not doing a lot of overhead lifting, might not be playing sports, and just need that shoulder to do the daily things that they do in their life. That same tear in somebody who's 50 years old, though, with a person who has a long timeline of shoulder use ahead of them, that person might play golf, they might have a laboring job, and we also have to think about that they might have 30 more years to live with that shoulder. And that small tear today could turn into a larger tear over time. So we might want to be more aggressive with that tear and try to get that patient to have surgery to fix it so they don't run into larger tears as they get older, because rotator cuff tears are known to progress over time. So activity level also plays a big factor. If you're 70 years old, but you're really active as a sedentary or even as an active 50-year-old, then we're going to sort of tailor that treatment to you, because we might think you're not going to do as well if we just send you to physical therapy or give you an injection to manage the symptoms. You may bleed through those treatments because of the high level of activity that you're doing. So we want to tailor that treatment to you as well. So hand dominance. If it's your right arm and you're right-handed, well, you might have more of a problem than somebody who has a tear in their left arm where they're not left-hand dominant. They might not use the arm as much. So I think that factors into it. Sleep disturbance factors into it. A lot of people otherwise can get through their day really well with a rotator cuff tear, then nighttime comes and it keeps them up at night. They can't sleep, and that really drives them to have treatment. And obviously we want to know response to prior treatment. If you've had 3 cortisone injections, 3 rounds of physical therapy, and it's not worked, I'm probably not going to recommend doing the same thing over again just to get the same result for you, right? So we're going to try to come up with an alternative treatment. And we can talk a little bit about alternative treatments, whether those be plasma injections, stem cells, things like that are more investigational at this point. But really, maybe surgery is a better option for those patients. We did a study a couple of years ago here at the Rothman Institute in our sports medicine practice, where we looked at patients that came to our office that ultimately had surgery for the rotator cuff. And we tried to compare men versus women, and as well as all age groups, and find out what really drove them to have surgery for their shoulder. And oftentimes for men, it was a really activity level dominant perspective. They oftentimes said that they couldn't do something they really wanted to do, whether that be play golf, play tennis, or do something that was labor intensive like their job. That's my daughter. So, for women, it was a lot different. Oftentimes women tended to have, they tended to have more sleep disturbance issues and things that kept them up at nighttime. So when you have sleep disturbance and you're not sleeping well, that affects your response to pain. So if you sleep 2-3 hours a night, just as much as you might be irritable, your body's more likely to be sensitive to pain. So we really saw that difference bear out, whether it be man versus woman. And so it was really interesting to see that. So we use that data from those studies to really kind of talk to patients about really what bothers them the most. What goals are we trying to achieve? Are we trying to sleep better at nighttime, but your activities during the day are okay? Or are you sleeping okay, but really your activities during the day are a real problem? And that can also point to a diagnosis as well. So also we want to look at pathology specific. So we've looked at patient factors, and we also want to look at pathology specific factors. My talk tonight is primarily talking mostly about rotator cuff because that's the most common problem that we see among the shoulder patients. 80% of people that come to my office really have rotator cuff problems when they have a shoulder problem. And about 20% are mixed labral tears or frozen shoulder or osteoarthritis. So chronicity plays into it. If you have a chronic problem, something that's been there more than 3 or 4 months, chances are you're going to be more apt to want a non-operative or conservative treatment approach. For a more acute problem, you're going to have much more pain, you might have much more functional deficit, and the treatment might be different because acute tears actually do very well with surgical intervention, whereas chronic tears may not do as well with surgery. Atrophy is a big factor. If you tore your rotator cuff and the tear's been there a while, the muscle may have shrunken down significantly to where even if we try to fix that tear, you may never rebuild muscle strength. Now, try like you might in physical therapy, muscle strength could still be a problem even after rotator cuff repair. So if I have a patient with a chronic tear and the muscle is atrophied or shrunken down, and their main problem is that they have weakness in their shoulder, that's a much tougher problem to fix with surgery. If their main problem is their pain, then surgery does better for that than it does for restoring muscle strength in those really long chronic cases. The second thing that or third thing that we'll look at is tear size. You know, when we talk to patients about rotator cuff tears, we look at the size, and really we're looking at how many rotator cuff tendons are involved. Is it just one tendon that's involved? Is it two tendons that's involved? Or three rotator cuff muscles that are involved? And that really dictates treatment as well. So larger tears might hurt more, but with surgery, they may not heal as well. Smaller tears may not hurt as much, but we may want to repair those because we don't want them getting to larger tears over time, which is very common. So it really also dictates treatment. A study years ago looking at patients with massive tears, I think the study was done in 2006 by an investigator, Dr. Yamaguchi, looking at massive rotator cuff tears, which means 3 tendon tears or more. And remember, there's only 4 in the shoulder. So if you tore 3 or more and you had surgery to fix them, he looked at those patients a year after their surgery and did an ultrasound to see how many of those patients had healed the rotator cuff. And he found that very little of those patients, I think he studied 18 patients, and 17 had not healed. But the interesting thing was that even in the patients that had not healed the rotator cuff, they were still doing well, that there was some benefit to surgery at alleviating pain because maybe they partially healed, maybe we removed the inflammation from the shoulder. And so while those patients were still satisfied with their pain relief, they did not get healing of the rotator cuff, and many of them still had weakness. That tear size then translates into tissue quality. So if you have a tear that's been there a long time, the rotator cuff tendon itself may not have adequate quality tissue. And remember, when we're doing rotator cuff surgery, we're not replacing the rotator cuff, we're actually repairing it. So we're taking the damaged tendon and repairing it to bone. Now we do have augmentation procedures. We can put little patches to help augment or make the tendon a little thicker, but it's still your tendon, your collagen that has to heal. When tears are really large or massive, you may have your surgeon tell you that it's not a repairable tear. And if you're in a lot of pain, that sometimes the best option is to proceed with a type of joint replacement called a reverse shoulder replacement that actually substitutes for the rotator cuff. So it doesn't replace the rotator cuff, but the replacement is configured in such a way that it substitutes for the rotator cuff and allows you to still move your arm. With rotator cuff treatment as well, we're looking at tendon retraction. Remember, when that tendon tears from bone, like I had mentioned, the muscle still contracts, and when it does that, the tendon accordions on itself. So the longer that tear has been there, it heals side to side. And when we as surgeons go in there to try to pull the tendon back to the bone and repair it, it may not come fully back. And that can affect repairability as well as healing rate of the tendon. And the last thing we want to take into account for patients with rotator cuff or even patients that are older is arthritis. Arthritis is when your joint starts to lose cartilage, and because of that, you lose range of motion and have increased pain. So if you have arthritis and a rotator cuff tear, just fixing the rotator cuff tear may not solve all your problems. You may still have pain. And in many of those patients, proceeding to a joint replacement might be the better option. So we look at all of these things specifically, and we try to come up with the best treatment plan for the patient. How long has the problem been there? Do you have muscle atrophy? Is it a large tear or a small tear, which indicates repairability and healing? Does the MRI show that you have reasonable tissue quality? And again, that goes to whether this is an acute or chronic tear. Is the tendon pulled away from bone so far that we would probably have a hard time getting it back? And do you have arthritis? And all those factors go in to the decision tree, as well as trying to meet the patient's demands and needs to determine what the best option of treatment is. So what are our options? Well, for the majority of shoulder problems, when it comes to non-operative treatment, you have medical management and you have surgical management. And for the most part, most patients will be offered some form of medical management, or they've already tried that treatment before they come to the office. So let's say you have something called rotator cuff tendonitis, which is just inflammation in the rotator cuff. No tear. And another name for rotator cuff tendonitis, we use these names interchangeably, is bursitis or impingement. We use all three of those terms to really mean the same thing, that the rotator cuff is inflamed and it's not working perfectly well. So we would try anti-inflammatories. We might try a cortisone injection, not into the rotator cuff, but into the space around the rotator cuff, which we call the bursa. And then we would usually recommend a physical therapy program to strengthen the muscles of the rotator cuff, to build that strength back up in hopes that that will cure a lot of these issues. We might even try that for patients with tears of the rotator cuff, because maybe they don't want surgery or maybe they're not great surgical candidates. So all that treatment option can be offered to patients with rotator cuff tears as well. And some studies have shown excellent benefit when even placed head-to-head against surgery for certain size rotator cuff tears, at least for short-term management of rotator cuff problems. How about arthritis? Well, arthritis is the same thing. Anti-inflammatory medication, moist heat, an injection of cortisone, physical therapies plus or minus when you have significant arthritis. In the early stages of arthritis, physical therapy may be very helpful, but as arthritis progresses, sending you to a therapist can sometimes be detrimental to your pain, as moving the shoulder can exacerbate symptoms and make them worse. So we have to be a little careful of physical therapy as arthritis gets more advanced. How about for frozen shoulder? Again, frozen shoulder, anti-inflammatories, a cortisone shot into the ligaments of the shoulder to try to loosen them up, and physical therapy to try to stretch that shoulder back out again in hopes that that will resolve over time. For our younger patients who have labral tears or biceps tendon problems in the shoulder, oftentimes we may not inject those patients just because they may not have any problems that are amenable to injection, as it's more activity-related pain, but we will try extensive physical therapy to see if we can non-operatively treat their shoulder problem. So when we go to surgical management, and again, I'm specifically here talking primarily about rotator cuff, we have really two options with rotator cuff surgery. Arthroscopic rotator cuff repair. What that means is we're going to fix the rotator cuff, but we're going to do it in a very minimally invasive way by making little poke holes around the shoulder, going in and repairing the total rotator cuff back to bone. Open rotator cuff repair essentially is doing the same operation, but instead of doing it minimally invasive through small little poke hole incisions, we're going to make an incision like the picture that you see here. And that the downside to open rotator cuff repair is it's a little bit more invasive. You can have issues with the deltoid muscle and excessive scar tissue form, but when you really look at patients at 1 year out, both treatment options seem to be very effective. So I have an example here I thought people might appreciate actually seeing a video of a rotator cuff repair. So what this is what we see arthroscopically. Arthroscopic surgery is looking like essentially through a video camera and a scope to look at the shoulder. What we see here is a little shaver that comes in to debride tissue. To my right, this area here, that's the ball of the shoulder, and below is the socket. This patient's essentially lying on their side. And you can see the ball. We look all the way around the shoulder. This is the back, a little bubble there that we'll get out. And that's the rotator cuff muscle essentially attaching to the bone. You'll see it right here. That's the part of the rotator cuff. This is the biceps below. I know it's not the brightest picture, and the socket's here where my mouse is. So now we go above the shoulder to look down. And what we see here is we're on the top of the rotator cuff. And we're cleaning out this space, which we call the subacromial space. We're creating a little pocket of space so that we can work safely in the shoulder. And this little shaver helps to remove some of that space. So what we see here is this shaver is getting rid of some tissue so we can get a good field of view. And below, right here, this is actually the rotator cuff tendon. Down below, this is the bone. And what I'm removing right now, that almost cotton candy looking structure, is actually the bursa. The bursa is the little fluid-filled sac in the shoulder that helps to lubricate the joint. It does grow back over time, even when it's removed. So as we do this debridement, this is just cleaning up the space where the rotator cuff is. And you can see where the shaver is and where my probe is now going is the actual tear or hole in the rotator cuff. So that's the hole that we're going to have to repair. You can see that probe lifts the tissue away from the bone, and the bone is below, down here where my mouse is pointing and where the probe is leaning against. So the principles of rotator cuff repair, and this is a rather small tear, would be that we reattach that tendon back to bone. And the way that we do that is first, we make sure that the tendon has mobility. You can see that I'm grabbing the tendon here with a little grasper. We pull it over, and we see, does that tendon get to the edge of the bone? And in this instance, the tendon does. So the next thing we'll do is debride the tuberosity. This is more looking down the tear, as you can see. There's the hole in the rotator cuff right here. This is the bone below, and this is the rotator cuff tendon above here. So what we need to do is remove the soft tissue from the bone to create a nice environment for bone healing and tendon healing. And then once we do that, we're going to put little anchors into the bone and stitch the tendon back to the bone. So the first step in that is using this little curette. And what we do is we just scrape off the soft tissue that's there. We don't want that tissue interfering with our ability to get the rotator cuff edge of the tendon healing the bone. So we just scrape off that tissue to try to get down to the bone. And you can see below that, the bone is this peach-colored tissue below where that soft tissue was. And I'm going to fast forward and advance this just a little bit so you can see now what we do is we drill into the bone these little anchors. So we create a little pilot hole, then the anchor goes into the bone, and what I'm doing right now is outside of the patient, I'm actually squeezing down the anchor so it deploys into the bone and gets larger so it gets fixation. Then I'll pull away that anchor or that sleeve, and you'll see the anchor behind. And what that is a piece of the anchor is in the bone now. It has a little eyelet in it, and 4 suture limbs will be coming out. And those sutures will then be used to pass around the rotator cuff. So in this patient, because of the size of the tear, we're going to put 2 anchors in. So we do the same thing over here. Once we put those stitches in, then what we do is we have to pass those stitches through the rotator cuff. And you can see we're doing that now. We grab the rotator cuff and the stitch. We have this little needle device that pushes the stitch through the tendon. We grasp the stitch, and then we pull it out of the patient. And then when we've passed all of our stitches, now we're ready to tie those stitches down. And again, we're going to pass all of those stitches through the rotator cuff. Once we do that, all of those stitches have been passed. Now we tie those stitches just like you would if you were doing the surgery open. You would grab the stitches you want to tie. What we do is we tie them outside of the patient, and then we slide them down through a little cannula into the shoulder and fix the rotator cuff. And when we're done, all those suture limbs are taken, and then they're taken through what we call a lateral anchor, and that anchor is impacted in the bone. So we've tied all of our stitches, we've taken the limbs of those stitches through that anchor, and now we're going to deploy that anchor to finalize our repair, to really sock it down. And we call that a double row repair because we use 2 rows of anchors sequentially in order to fix the tendon. I just thought everybody would get a kick of seeing how we actually fix the rotator cuff and what it looks like when we're done. So we remember the picture of what the rotator cuff tear looked like. We cut all the sutures, and this is what the final repair looks like. The tendon's now back down to bone. The stitches are in the tendon, and now the tendon's completely back to bone with no hole separating where the rotator cuff was. That tendon is now all the way back down to bone. So what's surgery like? So God forbid, and hopefully nobody on this talk ever needs surgery, but what's it like? Well, arthroscopic rotator cuff surgery, which is the focus really of my talk tonight, is done under general anesthesia, but we also use a nerve block. What that is when you, on the day of the surgery, the anesthesiologist gives the patient a numbing medicine to the nerves of the shoulder, and that numbs the shoulder completely. That also, post-operatively, when you wake up from the surgery, your arm is completely numb. That lasts for about 12 to 24 hours. It's different in everybody, and we do try to use long-acting nerve blocks now. When that nerve medication wears off, then you start taking pain medication for 2 or 3 days after that. We typically want to protect that rotator cuff repair. Remember, we've just taken that tendon that was torn, and we've reattached it to bone. So we have to put patients into a sling to protect that rotator cuff repair. We can let them move their wrist and move their elbow, but we really want to avoid any shoulder motion because that can really compromise the ability for that repair to take. That sling is anywhere between 4 and 6 weeks. 4 weeks for patients that have smaller tears, 6 weeks for patients with larger tears. During that time, we're doing some slight range of motion, but pretty restrictive. After that 6 weeks time, the sling comes off, and patients can then actively start using their arm as long as nothing is in the arm and there's no weight in the arm or anything strenuous. Once we have full range of motion, once you get comfortable using the arm, then we'll progress to strength training. Strengthening means rotator cuff strengthening exercises, and that typically begins around week 8 to week 10. We continue that all the way up to month 3 and month 4. At month 4, I'll have a conversation with patients about what is it that they really want to get back to. If they want to golf, I'll let them start doing short game golf, putting, chipping, the lower irons, just to see how a nice swing would go. If they want to play tennis, maybe some light hitting, but nothing real strenuous, and maybe only for 15 or 20 minutes at a time. We don't want a lot of repetitive activity, but we do want to try to train the shoulder to gradually come back. And we spend those last 2 months, the months between month 4 and month 6 after surgery, gradually bringing someone back, just like we would an athlete who is trying to gradually get back to sports and activities. We want to not have them do it all of a sudden, but gradually get to that activity. I would say most patients are back to almost all their full activity between month 5 and 6. But when you look at patients who have rotator cuff surgery and you look at their progress, they will make progress all the way up to 1 year after surgery. So I tell patients not to be too discouraged at month 6 if they can't do everything that they want to do, as they'll continue to make gains. The majority of patients do well after rotator cuff surgery, but it is a tough process getting there. You have to have close communication with the surgeon, with the physical therapist, with everyone on the management team, working together to get you back to where you need to be. But not skipping those steps in therapy is critical to a good outcome. Shoulder replacements is very similar, except we don't have to be as restrictive in the short term. So somebody has arthritis, they've gotten to the point where they need a replacement for their shoulder, which typically works very well, very similar to a hip replacement in terms of its outcome and success rate. But the first month is spent in a sling, then after that, we're a little bit more progressive with shoulder replacement, as those patients typically do physical therapy for about 3 months, and then make gains, probably maximum gains by 6 months. So it's a little bit of a shortened timeline. But rotator cuff surgery is probably our most labor-intensive post-operative recovery in terms of the shoulder. So I do want to thank everybody for tuning in tonight. I know I went over a lot of information, but my main point tonight was really to say, to talk mainly about rotator cuff, because I think that's the most common problem that I see, and to say really that if you're having pain more than 6 weeks, if you had a trauma that has caused you not able to lift your arm, if you have chronic pain that's been going on for some time, and maybe it's recurring, getting better, maybe it's recurring, it's helpful to know what the problem is so that you can prognosticate for yourself. Is it something you should take care of now? Is it okay to wait? Or should we be more aggressive in your treatment and do something so you don't run into problems later on? So anyway, thanks for your attendance, and I'm happy to answer any questions if people have them.
Yes, we have had several questions come through. First question, we're really going to put you to work with this one. Best general exercises for mild rotator cuff pain to strengthen, and can you demo it?
Yeah, so believe it or not, rotator, a lot of people think, I'll get a lot of people in my office who lift weights, and they come in with a rotator cuff problem. They say, oh, no, doc, I lift weights. I already do that stuff. And when I ask them specifically what they do, what we'll find is that they're not really strengthening your rotator cuff. When you go to the gym and you lift weights overhead, or you do bench press, yes, you're strengthening your shoulder muscles, but you're strengthening your deltoid, you're strengthening your lat muscles, and the big muscles of your shoulder. Rotator cuff exercises are very low demand, band type exercises. So in terms of the exercise that we do, the most important exercise you can do is a scapular stabilization or strengthening exercise. You might get a resistance band, put it around your doorknob or any sort of structure. You sit on the ground and you just take it and you pinch your shoulder blades together. And you do it repetitively, 15 to 20 repetitions, 3 or 4 sets. And that's one great exercise to strengthen your scapular muscles. A strong scapula will substitute for your rotator cuff and make your rotator cuff have to work less. Remember, it works in a 2-to-1 ratio relative to your shoulder. The second exercise is something called an isometric exercise, which means that the muscle doesn't really change length, but you're still strengthening it. You can go up against, essentially, I don't know if everybody can see me, but you can go up against a cabinet or a wall, just like this, and you push into the wall without moving anything, just contracting the muscles of your shoulder, and you hold it 5 to 10 seconds. And you do sets of that just like you would with your scapular exercises. Again, a very simple exercise, should not generate any pain, but actually works your rotator cuff muscle. And I would say the third exercise you would want to do is a forward flexion exercise like this, just overhead like this, with a light band resistance, no higher than shoulder height. Again, to strengthen your abductor muscles of your shoulder and your forward flexion muscle. You can take it also out to the side like this, very light resistance. It should not reproduce pain, and you should start with the lightest resistance possible, where you can do 10 to 15 sets. And if you graduate from that without difficulty, then you can go to an external rotation exercise like this, okay? So scapular exercise, isometric pushing the wall exercise, forward flexion, abduction to the side, and then a rotation. So that's the basic rotator cuff set that we try to have patients do.
Thank you. If there is no visible injury on an MRI, but you experience clicking, what could be the cause?
So clicking is the big mystery of the shoulder. Joints make noise, and joints that have problems tend to make more noise. When it comes to the shoulder, we don't really know the exact mechanism that causes clicking in the shoulder. Clicking can be normal contact, it can be abnormal contact. That's where this term impingement came from, that you lift your arm up overhead, and if you have a rotator cuff problem, remember the rotator cuff is supposed to keep the ball centered in the socket, right? But if your rotator cuff isn't working perfectly well, and you go to lift your arm up overhead, maybe the ball will rise out of the socket and make contact with the shoulder blade. That can cause a click. If your rotator cuff isn't working perfectly well, it's not centering the ball well in the socket, and you can go out anteriorly or posteriorly, and that can also cause clicking. One of the things that we'll find often is patients, for instance, have rotator cuff surgery. Remember, these are patients with a problem in their rotator cuff. They have surgery, they start getting back to strengthening, and many times they'll say to me, my shoulder is clicking a lot. What's the cause? And we'll have this discussion, and then they'll go through the rehab exercises, and they'll get stronger, and they'll notice that as they get stronger and the rotator cuff works better and better, it'll click less and less. Sometimes the clicking goes completely away, but sometimes it doesn't. But it doesn't always indicate that there's a problem in your shoulder.
Thank you. Good question. Do you have to have PT before you get an MRI?
So that really is dependent upon a lot of things. So there are like best treatment guidelines, or what the American Academy of Orthopedic Surgeons has is what we call clinical practice guidelines. A lot of insurance companies have latched onto these guidelines, and that determines who they qualify for MRI. It's very rare today, except for Medicare. If you have a private insurance, the majority of them require some level of pre-certification for an MRI. What that means is we have to submit our documentation to your insurance company that says this person has met this criteria, that criteria, and that criteria, and then you qualify for an MRI. Now, one of those criteria is physical therapy. So a lot of times you will need to have some physical therapy or demonstrate that you've done some directed exercises and haven't gotten better. Now, exceptions to that. Let's say you fell and had an acute trauma. You're 45 years old, you fell off a ladder, you felt a rip in your shoulder, and you come to my office and you can't lift your arm up at all. You probably will meet criteria to get an MRI in that instance. But if you have more chronic pain that's been going on more like 6 weeks, 3 months, you can still lift your arm, it just hurts. Most insurance companies, if they want pre-authorization for your study, will want to see that you've demonstrated a lack of response to physical therapy. And look, physical therapy, even if you have a tear, can still be very effective. It will not make your tear worse. It will not make the problem worse. It could hurt a little bit, but it's not making the underlying issue worse. So there's never any real harm to doing physical therapy unless you've got a dislocated joint or something really abnormal, but that should be picked up on your examination in the office.
Thank you. What is the standard treatment for frozen shoulder, and will it ever go back to normal?
So frozen shoulder, just very briefly, because I didn't really talk about that extensively. Frozen shoulder is a condition that is what we call idiopathic, which means we don't really know the cause of frozen shoulder. It goes through 3 characteristic phases. The first phase is called the inflammatory phase. That's where you get all this inflammation in the joint. You still have good motion, but it just hurts like heck anytime you move your shoulder. Patients then go on to the second phase of frozen shoulder, which is the freezing stage. That's where not only does it hurt, but now the capsule, the ligaments in your shoulder, have gotten so inflamed that they've contracted, and they will not now allow range of motion. So now you can't move the arm, and it hurts. Now, if left untreated, most people will go into what the third stage is, which is the thawing stage. And that's where gradually, the range of motion gradually comes back, and miraculously, over a period of time, it just gets better. Now, what do we do for treatment? Well, studies have shown that treatment might not necessarily make you go through the stages any faster, but it might make you more comfortable during the phases. And what we do for treatment is physical therapy to stretch the shoulder as much as we can. Oftentimes, we'll try a cortisone injection in the joint itself. It's different than a rotator cuff injection because this injection typically has to go in the joint, in the capsule or the ligaments to try to loosen them up. Patients might need 1 or 2 injections. And the hope is that that will help the pain a little bit so you can more actively participate in therapy. And the hope is that that will resolve over time. Now, there's a certain percentage of people that won't get better. They'll stay in the frozen stage, or they're locked in there for a long period of time. And those patients, they might need surgery. We go in there with a scope, and we just cut the ligaments that are actually torn. So instead of them being like this, we cut them like that. The ligaments do heal. They heal in a lengthened position. And the hope is that those patients can get back their range of motion. With treatment, most people will get back all their motion. The toughest thing for patients is they want to know, well, when is that going to happen? And to be honest, it's different for everybody. I've had some people where I've given them 1 shot, they've done 1 month of physical therapy, and they've treated their frozen shoulder, and it's better. And I've had some people that have had 9 months of treatment, and they're still not better and they need surgery, and some people that stuck it out for a year and then gradually got better. So it really is different for everybody. The toughest cases, for whatever reason, are people with thyroid conditions or people with diabetes, as frozen shoulder is associated with those conditions. And so I tell every patient who's been diagnosed with a frozen shoulder, get a fasting blood glucose and get a TSH. Make sure you don't have those underlying conditions, because the more adequately those are treated, the easier your frozen shoulder will be treated as well.
Okay, thank you. This gentleman writes, I am 74, extremely active in sports, including squash, court tennis, golf, and do cardio and weight training 6 days a week. The last x-ray showed bone spurs. Pain is more like twinges and intermittent. On occasion, reaching for something on a high shelf will produce the twinge. What should I do? Should I follow up with my surgeon? So I don't know what surgery they previously had.
Yeah, so I mean, it depends. So if the bone spurs are coming from the acromion, which is the shoulder blade, then it's more likely a rotator cuff problem. So for you, as active as you are, I'd want to know what's going on with your rotator cuff, right? I probably would say, you know, you can, if you've done physical therapy and you've really strengthened your rotator cuff, not just strengthened your whole body like in a weight room, and you still have pain, then I'd probably say it might not be a bad idea to get an MRI and see what your rotator cuff looks like, to make sure that you're not putting undue stress on it, so you can more adequately modify your activities so that you're not putting excessive stress. Now, if the bone spur is from arthritis, well, that's different, you know, and if it's from an arthritic condition, then that could get worse over time. But I would actually probably encourage you to maintain as active a lifestyle as you can, moist heat your shoulder now and again, and just be careful with how much weight you lift and how repetitive an activity weightlifting becomes for you. Because weightlifting is definitely associated with worsening arthritis of the shoulder.
Thank you. If I'm considering rotator cuff surgery, how long is the recovery?
So it goes in phases, but typically 6 months. You know, that first month is the sling. That's where you're really sort of like hung up. The second and third month are focused on range of motion. And the fourth and fifth month to the 6th month are focused on strengthening and return to activity. So it's really broken up in phases. What most patients are thinking about when they think recovery, they think, how long am I going to be in that apparatus, that sling? And that's anywhere between 4 and 6 weeks.
Thank you. Someone says, thank you for showing the surgical videos. I really love them. Hi, Dr. TJ. I raked and cleaned my flower bed on Sunday. Later that night, I had severe pain and struggled to go to sleep. The pain went away after 2 days. What should I do going forward so this doesn't happen? Stretch before I do yard work? Question mark. Thanks. Severe pain in arm and shoulder.
So it's good that it went away. It was probably about a rotator cuff tendonitis. And I would say, I would incorporate some of those rotator cuff exercises into your routine, because now you've identified as someone at risk for a rotator cuff problem. You put your shoulder through a little stress. It answered by saying, hey, we hurt. And so I think you should probably incorporate some rotator cuff exercises. The great thing about the internet today is that there's YouTube videos on rotator cuff. You can buy really inexpensive, cheap bands on Amazon.com and or other websites that sell them. And you can do a lot of these programs on your own, and they work really well. So I would say that if that happened to you, that once or twice a week, you do some rotator cuff exercise, and that might help keep those symptoms at bay.
And it looks like the last question that I have so far, unless anyone else has submitted anything else, is what does it mean to have a subluxed bicep tendon?
So your biceps is this muscle in your upper arm, right? And it has 2 heads to it, the short head and the long head. The long head of the biceps tendon goes into the shoulder and traverses around the shoulder joint. The long head's job is really to keep the biceps muscle suspended in the upper arm. It's not critically important for the function of your bicep though. So what is a subluxated biceps tendon? Well, that means that the biceps that normally goes in this little groove up into the shoulder and then goes into the shoulder joint itself is no longer sitting in that groove. It's out of that groove, and it can pop in and out of that groove. It typically indicates one of 2 things. Either you're overusing your biceps because you have a rotator cuff problem, right? Or you have ruptured your biceps pulley sheath. So there's a little sheath that holds the biceps in place. And if you've ruptured that sheath, it could also indicate that one of the rotator cuff muscles that's very close to that sheath has also torn. And the risk is that your biceps tendon could tear over time, because when the biceps is in its normal position, it's in a groove that's very smooth. It's lined with very smooth cells, so it glides smoothly. When it's not, or subluxated, subluxated means it's out of the groove, and now it's rubbing over something more coarse, and if you do that a lot, it can rupture. So what that means is that your biceps is not in its normal position, it's at risk of rupture, and it may also indicate an underlying rotator cuff problem.
Thank you so much. And then the gentleman who inquired about the PT exercises said that was a great demo. Thank you so much. That concludes the questions that came through on my end. Again, I want to thank you, Dr. TJ. I want to thank everyone for tuning in with us this evening. Just as a refresher, Dr. TJ sees patients out of our Egg Harbor Township and Manahawkin offices, and once a month he is at our Cape May Courthouse location. If you're interested in scheduling an appointment with Dr. TJ or with another one of our sports surgeons or shoulder specialists within the organization who may be closer to you, you can look for that on our website. I've also in the chat wrote our scheduling phone number. That is 800-321-9999. There's also a link there to click to submit to make an appointment. If you'd like to submit your information on our website, one of our scheduling representatives will contact you tomorrow in order to do that. So again, thank you everyone for joining. I know many of you want to refer back to those exercises and motions that Dr. TJ displayed. A recording will be sent out to your email within the next 3 to 5 business days. So thank you again. Dr. TJ, thank you for your time and your evening.
Thank you. Good night, everyone.